Hi, my name is Lisa Edmond, and I am doing my clinicals at University of Michigan, a facility of theirs, which is the Cardiovascular Center. What I will be discussing today is venous and arterial ulcers, ulcers on the leg, assessing them properly, treating them properly, and if not assessed or treated properly, what the end result could be. Ulcers are typically open wounds that stem from a breakdown in the skin. They can appear anywhere on the body, but they're typically seen on the leg, usually in the older population. But patients that have multiple chronic conditions and do not have as much physical activity will tend to have these skin breakdowns and ulcers. Ulcers can originate, or they are typically different mechanisms that can cause these ulcers, whether they're venous in nature, which most of them are. They can be arterial in nature. They can be a combination of both, or they can stem from diabetes. But the best way to treat these ulcers is to assess them appropriately. By assessing them, what I mean is knowing what type of ulcers there are, where they originated from, and from there, you can provide the appropriate treatment. With that point being said, venous ulcers are treated totally differently than arterial ulcers. And if you have a combination of both arterial and venous ulcers, then it takes a skilled clinician or physician to treat these ulcers. And if they aren't treated appropriately, it may lead to possible amputation. I will also be discussing the role that ultrasound plays in the role of assessing and treating these ulcers. Okay, so this is what happened. A 51-year-old male was referred to the cardiovascular center from an outside hospital. He had been having extensive ulcerations bilaterally, which extended from the knee to his ankles and were on his feet. They were demarcated, they were oozing, they had a pus, he had had gangrene, he had scaly skin in some of the areas, bark-like skin in some of the areas, and a lot of the areas the skin was just gone. There was tendon exposed, tissue exposed, muscle exposed. And he had been treating these ulcers for 2 years. At the outside hospital, initially he was diagnosed with having some type of peripheral venous disease, and he had been operated on, and they placed a stent. Well, as a complication of the stent placement, that's when the wounds began. Now, this peripheral venous disease was not the only health issues that this patient had. He had chronic hypertension. He had no congestive heart failure. He also had uncontrolled hypertension, a history of DVT, morbidly obese, and he had CAD. So, which is some type of arterial coronary artery disease. And when he presented initially with the severe edema and the ulcers on his leg and the history of having a DVT, initially a bilateral venous ultrasound was performed. The ultrasound was limited due to the obesity of the patient and when you got to the lower or to the calves, there was limited visualization due to the swelling. But not only was the swelling an issue, the fact that there was no tissue. So this patient was in severe pain. So you could not rule out clots in the posterior tibial, the perineal, nor the anterior tibial artery or vein. But in the upper, which is your deep system, there were no DVTs present. So from there, the next test that was ordered, which is part of ultrasound also, is a ABI-TBI or the lower arterial Doppler study bilaterally. Now, this was going to be limited in nature also because of the patient's pain threshold and the fact that he did not have any skin on the leg. It would have been impossible to place these cuffs on his leg. And you need these cuffs in order to get the pressures where you can determine the degree or classify the stage of disease that is present in the patient. The only area that pressures, well, not pressures, but waveforms were attained was of the toes bilaterally and DP, dorsalis pedis. No no cuffs were applied to the ankle, so we were only able to get waveforms. Bilaterally for the dorsalis pedis, they were biphasic, which is not normal. And then we were able to place cuffs around the toes, and we were able to get waveforms on the toes. One toe was normal, the other toe was abnormal. But how accurate was this with the degree of swelling or edema that this patient had? Well, the patient had wished for a bilateral amputation because of the degree of pain. But another complication of this issue was the patient was a Jehovah's Witness, which could have a great influence on the treatment that he is giving, and it could make a physician reluctant to go on with surgery because typically they, as a part of their religion, they refuse any type of blood transfusion. So the transcutaneous oximeter measurement test was performed, which is the TCOM. And not many facilities do TCOM tests. The TCOM test is a test that measures the amount of oxygen that is received to the tissue. So it shows the supply of oxygen and the consumption of oxygen. But it also shows possible amputation sites and the healing potential. So a TCOM was performed. Now, the TCOM machine, typically, this is a black and white picture, but it looks like this right here. There are 6 sensors, with the first sensor being placed by your heart, which is the source. 2, 3, and 4 are typically placed by the ankles, kind of in the gator zone, but you must have intact skin. 5 is below the knee, 6 is above the knee. Any hair present, you have to shave the hair off. You put fixation rings on the patient. You put a little solution in there, which it heats up. And then you put these sensors in those fixation rings. For each limb, it takes 20 minutes apiece. And you get readings. And you usually take the last 4 readings. Anything over 40 indicates that healing potential is good there and it's a good site for amputation. Anything below, that's not a good site for amputation. So the TCOM was performed on this gentleman, and pretty much it was ruled out that he would need bilateral above the knee amputation because based on these tests, he has a history of peripheral venous disease. With the ABI TBI performed, it ruled that there is a presence of arterial disease. Now, when you treat ulcers, venous ulcers are typically wrapped, and it's like a compression technique. But if they're venous and arterial, you really shouldn't be wrapping those because that compression wrapping can compromise arterial supply and do more damage and slow healing down. But if he has any type of arterial disease and the blood supply isn't getting there, that could be an issue as well. Upon investigation with this patient, they also suspect possible an unknown autoimmune disease. So they're not really sure if amputation is the best option because he may have other issues which are making these ulcerations appear and not heal. And the fact that, he's not that young, so to remove both of his legs above, and above the knee amputation is pretty drastic. So at this point, the patient is still being assessed by the vascular surgeons and dermatology. He's still being the wounds are being dressed, cleaned, and they're watching him. But the bilateral amputations have been held off until they can determine what autoimmune disease is present in this particular patient. Now, the TCOM exam, I think it pretty much shows the last step, what could be done for this patient. Because as you can see, the ulcerations are pretty bad. These are the ulcerations that appeared on his leg. These ulcerations have only gotten worse over the 2-year period and not better. So I think the role that vascular ultrasound has played in it, it has given an idea of how they should assess these wounds. It has given them an idea of where they stem from. They're not just venous in origin, but arterial as well. Also, the role of ultrasound has provided them with a possible treatment. It's drastic, it's not popular, but it has provided them with the information that if they were to do an amputation, it would need to be above the knee. That is where he has the greatest healing potential. So this would keep the patient from getting an amputation, say, below the knee, that not healing properly, him having complications, and then they have to come back in and do another amputation. So I think the role that ultrasound plays in the assessment, the treatment, and the possible outcome in the end is pretty great. It may be limited to a degree based on the truthfulness of the patient, the compliance of the patient, the nature of the diseases, the extent of the diseases. But I think ultrasound plays a great and key role in the assessment and treatment of the patient. I felt very honored to be a part of this study. It was a little personal in nature for me because my father had not as bad or not as severe, but he had ulcerations on his legs that lasted a year. But once a stent was put in, the wound started to heal. Up until that point, they weren't healing. So this was a little personal to me. And not many facilities, like I stated earlier, have the TCOM machines. And I was very glad to be exposed to learning what a TCOM test is, aside from reading about it in a book, and to actually perform one with the help of Shannon Strachan. This is a black and white picture. I don't want to drop the computer trying to, well, maybe I can scoot back so you can see it on the poster. Well, that's not doing too much good. It may make you dizzy. But it's a black and white picture, and it sort of shows you where this is, well, where the sensors are placed. This would be 2, 3, and 4. And these are the fixation rings, which is applied to the skin, and then the little sensor that goes in that fixation ring. I know this isn't like the best diagram, and it's in black and white, but this gives you an idea. And these are the machines, and these are the readings. Those readings are numbers that are on your report, and it lets them know what your healing potential is. So not only do you need a lot of, a lot of tests ordered, like were ordered in this case, you need a skilled physician, nurses, good wound care, and um, just the patience and diligence of a good medical team to treat these complicated ulcerations if they're mixed in etiology or origin or mechanism. Um, so I'm not sure how interesting this was or how much it helped, but I was glad to be given the opportunity to share this with you guys and let you guys see what we are doing at the CVC and what has been a part of my education so far. Thank you, everyone. Have a nice day. And here's my poster. Oop, I'm not doing too good with this machine, with the computer. Oop, maybe I need to bring it up. So those are the ulcerations. Oop, the TCOM machine. I'm not good at this. More of the ulceration. And a little fixation ring. Once again, thanks, Heather, for allowing us to do this on video. Bye bye.